those who are joining the call outside of UCSF. I'm Dr. Teresa Kortz, and Sohel Sood and I are co-directors of the the Global Health Scholars Program here at UCSF, and we host an annual Global Child Health Lecture Series. And so thank you so much for joining. Today I have the great pleasure of introducing Dr. Jason Bacha. He's an assistant professor at Baylor College of Medicine and works with the Baylor Initiative on Pediatric, I always mess it up, BIPI, Baylor Initiative for Pediatric AIDS, no, Baylor International Pediatric AIDS Initiative. Did I get it right, Jason? Yes!
Nailed it.
Oh yeah, right, on the third try. It's a mouthful. But he does incredible work and has been in MBEA for a decade now, and one of the centers of excellence, providing both HIV care as well as amazing tuberculosis care, and is one of the leading researchers in tuberculosis in Tanzania. And so we're really excited to hear about your path and your work. So I'll let you take it from here, Jason.
Great. Thank you so much, Dr. Teresa. And again, I'm very excited and honored to be able to talk to the group today about a topic that I think is important and near and dear to me, about embracing a patient-centered approach to researching global health. I'm also just going to turn off my video to preserve bandwidth as well.
And I can keep track of the chat for you, Jason. Sorry.
Okay, wonderful. So before we jump directly into the topic, I'll give a brief overview and snapshot into the global health career path that I took. I think, at the end of the day, global health and those of us in global health are driven by that motive, which is so nicely summarized as the desire to work together towards a future in which where your patient lives doesn't determine if your patient lives. So for me, I like to weave a lot of global health experiences through my academic career, be it undergraduate, medical school, and then in residency. And of course, as I've highlighted here, really, it's trying to find and locate these like-minded peers and mentors that will act as people to give advice and inspiration and to really help you find different experiences and resources that are out there. There's been a huge explosion of interest in global health throughout med schools, almost all residencies, including pediatrics. So it's a growing, thriving field, and there's a lot of current interest. I met my wife, Dr. Leanne Campbell, who gave an earlier lecture during our residency. We did some international rotations together and experiences, and then we applied to a job together. As Teresa mentioned, we now work with the BPI, Baylor College of Medicine, their International Pediatric AIDS Initiative. We live in MBEA. You can see in the top right, it's southwestern near the Malawi and Zambian borders. We've been faculty and here in Tanzania, living and working full-time since 2001. So this is actually our 12th year on the job. The BPI network is part of a broader network of Texas Children's Hospital Global Health Network. This is a quick snapshot of where they work. On the left hand, you can see they do much more than just pediatrics and HIV. Specifically myself, I'm also a faculty member with the Baylor Global TB program, providing TB care and TB research. And then our team here also works pretty closely with the Global HOPE Hematology Oncology Pediatric Excellence Program, providing pediatric oncology and hematology care. So, what is the role of a global health physician? I think as physicians, we all juggle sort of these four roles and wear these four hats, be it clinicians providing care, educators teaching, mentoring others, researchers, be it clinical research, implementation research, or bench science research, and of course, advocates and public health workers. So what I really like about our job here is we get the opportunity to really wear all four of these hats, and it varies day to day, week to week, but it's exciting work because we do get to see patients, do a lot of education, get involved in research, and get involved at the national, regional level on guidelines and committee work. So it's an exciting job that fits us very well. I also like to point out at this point, this Japanese concept of ikigai, and it's this concept of finding your reason for being and sense of purpose. And it's essentially finding the intersection of what you love doing, what you're good at doing, what you get paid to do, and what the world needs of you. So really, I'd encourage all of you as you're forging forward with your careers to work hard and think about this, because you'll definitely be happier if your work life and your life can cover most of these 4 topics. So that was a brief origin story of myself and my global health career. As for the origin of today's talk, so is this part of the TropMed exam domains? No, it is not. And it's really a talk that developed organically from visitors and talking with local teams. And its aims to provide a bit of perspective and practical advice, foster this global state of mind towards research and doing research. And at the end of the day, it's about thinking and framing how to prioritize and design patient-centered, partner-driven, simplified approaches to our clinical research. So how best to enjoy these slides? I like to remind everyone of the forgetting curve that's been known for centuries, and there's even been a team that did a recent study to prove it still exists. And it's basically the principle that the human brain isn't designed to remember everything after one lecture or hearing it one time, but really we need to make it meaningful to our lives, repeat it, and do it over and over before something sticks. So I mention this because I know this single lecture won't last with you forever, but it can also be used for future references as a toolbox to revisit it at the right times in your life and career when you need a refresher or some practical advice. I also like to mention the forgetting curve, because as we think about doing any kind of global health or teaching or mentoring or implementing an intervention and study, knowing that one single training or one single event in time really will not be enough. And it's about making it something sustained, repetitive, and learned over time. So the outline will really discuss 3 topics of research and research framing and approach. 1, patient-centered research, which is the crux of the talk. We'll also talk about the importance of partner-driven research, and lastly, the importance of simplified research. And really the objectives is, I hope by the end of this lecture that we'll be able to really think and create a framing of a patient-centered framework for clinical research projects and design. We'll be ready and well prepared to prioritize the partnership across clinical research projects, as well as to cultivate and grow some skills and characteristics that will enable effective clinical research. What we won't cover during this talk, because research is a big topic, so we won't be covering protocol development, securing research funding, IRBs and country-specific research, approvals, or actual implementation. Those are very site dependent. They can be challenging, difficult, lots of hoops to jump through, but as you go to sites or countries and work with your teams, you will have mentors and guidelines and people to help work you through those, but we won't be covering them here. And essentially, I hope by the end we'll turn our F's into our A's, our frustrations, floundering, failure, futility, and fears into adaptability, awareness of resources, adjustment, acknowledgement, and really awesomeness. So moving forward, I like to use this framing and thinking of approaching clinical research through what is well known and published as the 5 R's of global health. Here they are listed of these 5 characteristics that really help someone succeed in global health and working outside of your home country. They're respectfulness, reciprocity, realism, resourcefulness, and resilience. Specifically with research, these are all important characteristics, but this talk we're going to really focus in on respectfulness, reciprocity, and realism. I like to mention here, you'll notice that one of the 5 R's is not an NIH R award. While it is important, it's not necessarily the highest priority. And essentially, here's a Venn diagram to think about how to merge those R's into the patient-centered, partner-driven, and simplified research. And really, if you can think about these, focus them with intent carefully into your research projects and design, you can create a really successful research project. So we'll start with the importance of patient-centered research, this idea of respectfulness. And I always like to start this portion of the talk with a photo of the Choluteca Bridge. For those who may not be aware, this is a bridge that was built in Honduras and finished in 1998, which was the same year that Hurricane Mitch hit and caused a lot of damage throughout Honduras. And what was quite interesting is while many bridges were damaged and many destroyed, the Choluteca Bridge survived with very minor damage. And while it survived this hurricane in near perfect condition, the roads on either end of the bridge completely vanished. There was no trace of their prior existence. And even more impressively, the Choluteca River, which was several hundred feet wide, had carved itself a new channel, a new direction due to the massive flooding. And so basically, despite amazing design, the most and best engineering and technology of the date, they ended up with a bridge to nowhere because the river underneath shifted. And I think this is just a lovely metaphor for if we design an amazing project, but don't pay close attention to the needs of the populations our research is meaning to serve, those needs shift and change, and we might end up with a research project to nowhere. And here's a quick look of what the bridge looked like just before Hurricane Mitch. It's also really promoting this idea and mantra of nothing about us without us. This is the idea that no policy should be decided without the full and direct participation of members of the groups affected by the policy. Loads of advocacy groups use this. It's a driving force behind a lot of policy. And really, I think it should be a driving force behind our clinical research projects and research project design. At the end of the day, it's about this importance of equity and equitable design of our clinical research. I'm sure many of you have seen this picture before. This idea of equity is giving people not just the same for everyone, but really looking at what each person, community, population needs and designing interventions to fit those needs. Unfortunately, this is what we see more in reality, this idea of a cycle of corrosive disadvantages where the vulnerable and healthcare populations are typically members of groups who already are disadvantaged on many levels, and these disadvantages lead to further disadvantages, so forth and so forth. And of course, our social and humanitarian advances do lay behind many scientific advances we make. So it's important to keep this idea of equity in mind with our clinical research. As a step forward with this, we need to be cognizant of fighting bias and stigma, not only in healthcare, but also in clinical research and research design. Throughout this talk, because of my background, I often use HIV as examples, and I'll use it throughout this talk. But of course, you can swap out any type of chronic health condition, patient population, and the ideas hold true throughout. So again, it's this idea of we're working together to fight the virus, not the people fighting AIDS, not people with AIDS, and really trying to minimize stigma and extra burdens on the populations we're trying to serve. It falls in line with the idea of implicit bias and trying to recognize as best we can our implicit biases. There's lots of research about the impact this has as clinicians in our clinical care, and how these unconscious actions can really result in unequal care and influence our diagnosis, treatment decisions, many of our nonverbal behaviors. But I also looked, of course, reflected at Tanzania, and there is high levels of stigma reported in Tanzania as well. So it's kind of something happening globally and that we do need to address. But what about thinking about our implicit bias when it comes to clinical research and research design? In any study you read or any study proposal you write, you're always explicit in your methodology. How are you minimizing your bias? How are you minimizing your recall, selection, observation, confirmation, publishing bias? The list goes on and on. But rarely, if ever, do you see the study authors talking about how they're thinking about addressing and minimizing their implicit bias within their methodology. In fact, when I tried to do a lit review and see what I could find, I really could only come across this one article from last year, 2021, that has a couple paragraphs about how implicit bias can have impacts and effect in clinical research design, and how it can, implicit bias of the study teams can impact your study recruitment, your study retention and care, your protocol adherence. So it is something that I really encourage you all to think about when you're working on proposals, design, and methodology. Again, to maximize the research benefit to the populations you're hoping to serve. Moving forward with this is also thinking about the language we use and really focusing on patient-centered language, of course, in clinical care, but also in our clinical research design. And it's really this idea of following not so much just the golden rule, but the platinum rule, which is to treat others as they wish to be treated. Thankfully, there are many, many wonderful, excellent resources about how to use patient-empowering, destigmatizing language. Here is just a couple examples of those resources for HIV, which again, we really need to read about, focus on as we're using these language to have research design, interacting with research participants. It is extremely important. There are also great resources for tuberculosis. UNAIDS has a good resources, and it's really focusing on this patient-centered approach to the language and words we use, while remaining receptive to feedback from those who are most affected by such stigmatizing language and prioritizing the expertise from their lived experience. I like to take a portion where I just give a couple examples of some of the language that still is out there and frequently used. I hear it a lot at meetings, in reports, and protocols. One is this idea of retention to care. We see it all the time in reports. PEPFAR indicators have been retention and retained in care. But when you think about it, it's a possessive word. The word retain generally does not have good positive connotations. And instead, there's a big push to talk about engaging and keeping and having participants, patients engaged in care. As some of the HIV advocates say, the HIV treatment cascade is not a correctional facility, and we really should focus on not referring to participants, patients as objects. It's not the idea that the clinician or the researcher, for example, initiates the patient on a treatment, but rather the patient themselves decides to take the treatment or decides to participate. Another word that we see a lot, especially in the HIV world, is hard to reach, and these hard to reach populations. But again, to use a couple quotes of the affected populations, it's don't use hard to reach just because you don't know how to reach us. And it's also putting, intentional or not, more of the blame and more of the responsibility on the patients and communities themselves, and absolves the clinicians, the research community of their responsibility. I like this tweet as well that said, these are not difficult to reach people, only the services which are not well designed. So it's really important to kind of shift the framing of our languages and our words in highly affected community, or as some of the talks had said, hardly reached and unsuccessfully engaged populations. So again, when thinking about your research, your protocols, your language, your reporting, it all starts with our language. And we got to remember that the people, the patients, the participants, they're not just hosts for disease or trial subjects, but they have awareness, they have agency, and we really want to ensure that our research uses empowering, non-stigmatizing language at all levels. So not only is patient-centered language important, but really going back to the nothing about us without us, focusing and prioritizing patient-led, patient-driven clinical research. It's this idea of conscious active inclusion, where we're consciously, actively involving affected communities from the start, actively seeking their input, feedback, opinions, and letting our research ideas be shaped and refined from their input. Thankfully, there's actually some really nice, really useful resources out there. This is a good practice guide about greater involvement of people living with HIV in program design, intervention design, research design. Again, this one is specifically for HIV, but you can use the words, the lessons in it across all kind of cadres and across all kind of sectors. Even the pharmaceutical and biomedical industry, there's been a big push of getting more insights from those affected across all stages of clinical research, because again, they have the most intimate knowledge of the factors that affect them in their communities. They have the firsthand experience of the realities, and it's working hard to create meaningful spaces to get good input from the get-go and throughout the life of the research project. There's also a really lovely, easy to use checklist, self-assessment that programs, that organizations, that research developers can use. And it's really to get affected communities as engaged as possible, not just as external contributors, but really as external and internal contributors throughout the life of the project. Which sort of goes nicely into the rise of and use of community advisory boards when you're designing your research projects, and how important it is to think about them from the start and get them involved throughout. They serve as a wonderful voice for the community, for study participants. They bring their unique experiences. They should be involved as much as possible at all steps along the way. And we work a lot with children and adolescents. Some of our projects we're launching and utilizing youth advisory boards that use adolescents, consenting adolescents as well, for projects involving adolescents. So it's an exciting thing. I encourage to try to incorporate a community or youth advisory board when at all possible. And it's also, overlaps really nicely with some of the new health and clinical care delivery models. And is there some opportunity to weave them into research design? Specifically in the HIV world, there's this idea of differentiated service delivery models, which at the bottom you can see is essentially a client-centered approach that simplifies and adapts services, HIV services in this case. And it again pushes back against some inherent biases historically of aid intervention and puts more trust and responsibilities that really individuals and communities will and know how to make the best decisions for themselves. So it's thinking about, is there room to weave some of this into research design? We're making it client-centered, simplified, and adaptable. One example that caught fire over the past couple years was this cash transfer model. And it's kind of the idea that typical aid and intervention in many clinical research efforts take the form of in-kind goods and service, be it an education package, some sort of skill building, maybe delivering of vaccines or medicines, housing support, food packages. But this can often be tricky, costly, logistically difficult. And so some of the research design had two arms where they did the intervention to some groups and they just gave cash to the others. And they found out that often just giving cash results in as good, if not better, because the families, the communities, they know what they need. And we sometimes say no amount of nutrition education can substitute actual food and sustenance. You can't eat and grow off of nutrition education alone. And often for communities with high risks of poverty and high levels of poverty, it's getting some sort of cash that helps them. And this has actually led USAID to start using cash benchmarking as an approach to aid or intervention, or even the idea of clinical research, where if you're designing an intervention, you might want to think and consider, will cash be a good gold standard comparator intervention to think about and use? Lastly, when talking about patient-centered research, I just want to touch upon this growing momentum of the importance of emotional intelligence. There's been a lot of great evidence that physicians, clinicians with higher emotional intelligence have much better patient outcomes, higher patient satisfaction and trust, better job satisfaction, less burnout, or essentially better doctors. But what about in clinical research? There is not much out there about the importance or how much we should or should not prioritize emotional intelligence as clinical research. This again was one of the few, if only, articles I that was able to come across that sprinkled it throughout. And really, I would advocate that I think emotional intelligence is a key important quality for clinical research. It's the idea that we need to design and implement research that's compassionate and research that not only has brains or doesn't only have brains, but also has heart. And I think like medical schools are now really focusing on the emotional intelligence of their applicants. I'm hoping that in the future, research institutes, funders will consider emotional intelligence of the research as part of their proposals, potential staff, and funding requirements. So something to reflect upon in yourselves as clinicians, of course, but also as clinical researchers. So moving on to the second pillar, this idea of reciprocity and partner-driven research. And it's this idea that's been growing stronger and stronger over the past decade of prioritizing the partnership and shifting the partnership more towards host institutions and their priorities. Again, there's really nice ethical guidelines for anyone going to an international site about best practices and how to focus on the partnership. And this applies also to clinical research. And it's the idea that we really need to reach out, work together with local partners, local researchers, and prioritize their needs, their interests, and harmonize them with our projects. It needs to be bi-directional collaboration at each and every step, from development, from funding applications, from the research design and hiring, data collection, data analysis, writing up, publishing, attending conferences. It needs to be hand in hand and bi-directional. And of course, what this means for some of us is that often you need to negotiate, meet in the middle, and be flexible. You may have an interest, a unique disease, a unique neglected tropical disease, bacteria. But if it's not something that's a huge priority or even a huge burden on the area you're going to work, you might need to be a little bit flexible and make that maybe a secondary or a stepwise idea. This is a slide actually taken from a UCSF online lecture I watched a couple years back from Dr. Pai about his global health research needs more than a makeover talk. And really, he talked about how international health partnerships have historically been very unbalanced, where our academic teaching hospitals have often gone to lower income countries and use those sites with this, quote, parachute research approach of swooping in, doing the research, swooping out, and taking the data. And thankfully, this is becoming much and much less common today. Organizations, academic centers, researchers are more aware of it. But of course, subtle variations of this practices still do occur, and they have risks of coming and going in waves. So we do need to be aware of it. There's been a nice core components of equitable global health education recommendations published. You can see here number 6 and 7 really focusing in on this prioritizing of the partnership, because our local partners are those true experts on the topics related to their sites, their healthcare delivery, and their settings. And we really need an unwavering commitment to them to strive towards reciprocity in all opportunities. And again, it's this idea of sometimes as big, well-funded academic institutions, we need to think about leaning out to let our partner and host institutions and their clinical researchers lean in more. This idea of being enablers more so than leaders. You know, how can we achieve this? As mentioned, it's really about thoughtful, rigorous pre-study, pre-submission, pre-protocol preparation, engaging, identifying local partners early, often, and always, ensuring our studies, our research, our presence is really going to benefit the needs of those communities, and ensuring the research is of value and interest to our partners. You know, what some best practices we can do, really try to match your skills with partners' needs. consider either a phased study approach or stepwise approach to your study, where maybe your interests might come at second, third phases or later years of the study, or even piggybacking some specific interests into larger study as secondary or tertiary objectives of a study. Lastly, moving on to the third pillar, this importance of simplified research and realism. Once we have a study site identified, a protocol, and we're ready to move into study design. This principle of realism in partnership and international work is the idea that every new environment we experience requires quite a significant period of adjustment, calibration, recalibration, and realizing what is realistic and sustainable. Can be a locally driven solution and context specific. It's also thinking well and hard about knowing we're going to be a burden. That's just a fact of life, fact of global health experiences, fact of clinical research. And what can we do to minimize the amount of burden ourselves and our research is going to place on host institutions? I really like this article and would recommend everyone reading it, about Training for a Global State of Mind by Dr. Jane Philpott. She's a Canadian physician advocate, was a former Canadian Minister of Health. And in this article, she gives a list of motivations she's heard and seen over the years to do global health work, be it clinical work or research, of motivations should rather suppress and rather see suppressed, motivations that can be tolerated, and of course, the motivations to which we all should aspire. I won't read this bullet point by bullet point, but I definitely recommend, if nothing else, looking at the table of these motivations to which we should aspire as, clinicians with a global health of mind and clinical researchers with a global health of mind, global state of mind. So thinking about clinical research simplicity, I thought it might be best presented as a series of lovely quotes about being simple. I like the quote of, "The most complicated skill is to be simple." You have excellent training. Many of you are brilliant clinicians, clinical researchers, and now the challenge is going to be to take all of that and have an effective but simple research design. The second quote, "Simplicity is a prerequisite for reliability." If you make a study too complicated, too many steps, too many interventions, too many algorithms to follow, often it gets difficult to implement effectively, for study teams to reliably repeat, and you lose your study reliability and impact. Third quote, "Simplicity is an exact medium between too little and too much." Again, there's a key difference between simplistic and simplicity. It's not about dumbing down your study and your intervention, but finding that balance where it's enough to answer the study questions and be impactful, but not so much that it's impossible to implement, and even down the road, impossible to replicate outside of a study setting. The quote of, "Complexity is impressive, but simplicity is genius." Again, we can all make studies that are extremely complicated, highly involved, but when you're working with hosts and local partners, there's often not high levels of capacity to do these extremely difficult studies. And lastly, simplicity will stand out while complexity will get lost in the crowd when you're thinking about the data collection and what you want to write out. If it's too complicated, too nuanced, it involves too many what ifs, it might not be a practical long-term message, and your study might not have any real-world, practical, effective results. Sometimes we joke about, often we got to work to ride and nudge towards the path of least resistance. These sites often have massive human resources for health shortages. They're overburdened, overworked, on the brink of burnout. And a survival mechanism in many sites, mine included, is often taking shortcuts, going down the path of least resistance. It's just a reality right now until these human resource issues can be improved and solved. So we really got to realize that's a reality when we're going to sites, when we're bringing studies and research partnerships. Some common pitfalls that we see here at our site, across the region, across our network, has been trying to cram too much into too short of a period. Many times, visits and learners, residents, fellows, early career researchers, their time overseas is short. It might be as short as a couple days, couple weeks, a couple months, maybe 6 months, and they try to cram too much into too short of a period, and often challenges can come from that. Another common pitfall is having excessive and lofty data and/or sample collection goals, designing a REDCap database with the idea of I want to capture everything because maybe in the future I'll revisit it. And so you have these surveys, questionnaires that are massive, they're long, they're time consuming, they take hours, and then the data quality gets really low and poor, shortcuts are taking, participants get tired and bored and don't give great, honest answers. So having too lofty, too big of a questionnaire or REDCap database can be detrimental in the long term. And then a third common pitfall we've seen, experienced, struggled with here is this kind of fallacy of partial salary support or percent effort for study staff. And I know funders love this idea of 25% or 50% will go to a local staff. But the reality is all of these local staffs have 110% responsibilities before the study, your study came, and having just partial support while they're doing their normal jobs, plus now a little study work, often leads to bigger problems and challenges with successful implementation. We've had a lot more success. We've seen partners have a lot more success when a core 100% study staff is hired to implement, recruit, consent, collect samples, questionnaires, follow up. It's much easier when you find someone who can do that 100%. That is their job. It's not to say you can't work in some others, but to expect someone who has full-time or near full-time work to also implement a study on the side is a lofty and almost unrealistic study expectation. So, what we can do to embrace this simplified approach, be thoughtful, really think about the burden yourself, your visits, your study is going to have, when you can, and the budget and the funding allows, budget for full-time study staff. Think about other cotters if certain high-paying cotters are too expensive, community health workers, people living with the condition, volunteers. There are ways to maximize limited study budget, but trying to have full-time 100% study-specific tap. And then simplifying when you can, this idea that something does not need to be perfect to be wonderful. So in summary, I want you all to have a framework, a lens to think about creating, designing, implementing, seeing clinical research through. It involves involving affected communities from day 1 to 1001 every step of the way. Be sure to use the right words, empowering messages, prioritize that partnership and local teams, and of course, to keep it simple, smarty with your design and interventions. Again, revisiting the Venn diagram, for me personally, I think being patient-centered in our research should be the biggest of the three, while all, of course, are very important. And revisiting this idea of nothing about us without us, the idea that no research should be decided without full and direct participation of the members of the groups and community affected by your research. As homework, if you have the time in your busy schedule, this was that lecture from UCSF 2 years ago. I thought is wonderful, required viewing for anyone who wants to do global research outside of the US or even locally within the US in vulnerable communities, because as we know, global health is essentially anywhere you put your feet. The AAP also has a really nice preparations for working in resource limited settings. I like this idea of there are these challenges and ideas, things to think about regarding you'll be in a different country with a different clinical context and a different healthcare system and many challenges to be prepared for. And then lastly, to revisit our pictures of the Choluteca Bridge and finish on this image as a reminder that not only do we want to create robust, strong, sturdy, impactful bridges of clinical research, but we need to also continuously be aware and flexible enough to keep pace with the changing flow of the river below it, which are the needs, the concerns, the opinions, the values, and the struggles of the communities and populations that we aim to serve with our research and of the local partners we will be working side by side with. So I thank you all for your time and listening. My email is here in case down the road you have questions about careers and life in global health or about clinical research projects in design. So I think we have a little bit of time at the end, hopefully, for some questions if there are any from the audience.
Thank you, Jason. That was really inspiring. I wish I could have seen your talk about 10 years ago, but that was incredible. I'll open it up to questions, and just to say as well that Tiffany's put a brief eval in the chat. It's just a link with like 3 or 4 questions, and we highly value your input and your feedback. So if you could take just a minute to do that. And then any questions from the group? I had a question for you, Jason. Actually, you're the second speaker, or maybe we've had a couple now who have mentioned the real impact and value of having a youth advisory board. And so my question for you is, what are kind of the unique considerations when you're trying to create a youth advisory board for a topic and a subject that can be quite stigmatizing, such as HIV? If you could just speak about that, that would be really interesting.
Yeah, absolutely, and so important to consider. So I think first and foremost, unfortunately, you can't just go into a location and start up a community or youth advisory board, but you really do need to talk to the local research approval bodies, ethical bodies, if you're partnering with a host institution. Many already have guidelines and recommendations, some do not, and so you'll be co-creating them together. But you do need kind of the higher up side and below approvals to do any type of advisory board. First, to know who to involve, how to reach and find the right communities. Specifically with youth, and for potentially stigmatizing topics such as HIV, such as gender-based violence, intimate partner violence, you do need to be careful. For us, sometimes you have to look at local context and sometimes even local laws about where consent is happening, be it consent for HIV testing, consent for marriage, and you might only be able to go as young as that age. You always want to try to obtain assent/consent depending on ages, and where it's assent involving the guardian, because as much and as important it is in some topics, you really just want to talk to the adolescents. You don't want to go behind the parent or the guardian, and that can cause more problems. So it often requires a delicate approach involving this local context-specific laws, regulation, consent ages, and then when necessary, at least letting the parents be aware. They don't have to know all the details. Obviously, what is said in these youth advisory boards is fully de-identified, confidential to just the study team, and won't be shared with parents, guardians outside. So it's challenging, but the input that you get is so valuable, eye-opening, and just wonderful to hear, and it does help shape and improve the study and design.
Thank you, Jason. Really appreciate the insights and agree with Teresa. Hopefully those that are 10 years younger than us are getting it for the first time at the right point in their careers. And I suppose I wanted to ask a question from that perspective of a trainee from the Global North, let's say. What you presented, I think, is a very appropriate and thoughtful critique of the system. But as a trainee, let's say you're trying to find, you're in it with the right intentions, and you're trying to find the right mentor and the right project and working through it, and you're finding some things that maybe don't align with the principles that you've just raised as the ideals for the system. And so what advice would you have in that situation? What are your thoughts on incrementalism? And do you have any, personal experience having had to ride through some of those hurdles?
Sure. I mean, yes to everything you said. Incrementalism, it's challenging as a trainee. There's a lot going on. You're young in your careers. You're learning all the, for lack of a better word, the politics and nuance of these partnerships, of clinical research design. So it is difficult. There's many external pressures, timeline deadlines. So it's hard, to requote myself. Something does not have to be perfect to be wonderful, but at the same time, if we're gonna pick and choose where we, won't be able to meet everything, we do have to be thoughtful about it. And we really should be prioritizing the partner, the community we're serving a little bit over our interests. I would recommend, thinking back to when I was early in my training, finding a mentor who you can have these open, honest discussions with is important. They're going to be so helpful. A mentor who has a good relationship, ideally with a local partner. If it's a brand new relationship, that's a slightly different story. That's where some incrementalism helps. And that's where you might have to decide, do I put my passions and my interests in the back pocket, as they say here, in the parking deck for a little bit, to focus on something that is more valuable to the local team in the local context or the local researchers? Or do I push forward and if you're seeing where maybe it's not perfect, where maybe there is that colonialism in the research design, it's okay and important to speak out. If you're going into this career and you want to be an advocate, you're going to have to learn to speak out, to be uncomfortable, to put yourself on the line at times. Hopefully it's minimally when you're a trainee, because there are those imbalances of power between mentors and trainees, as there are to academic sites, to host institutions. So it's a tough learning challenge. We've all gone through it. There are times I've wished I've spoken up earlier, and now I've been stuck in research designs that aren't ideal, and nudging it while it's implemented in a short-term 5-year funded study is harder than having designed it better at front. So I would highly recommend really focusing at the beginning as much as you can, but it is true sometimes you'll piggyback into an existing research study and ride it out, do the best you can.
Another recurring theme. Oh, sorry, does someone have a question? Another recurring theme of our lecture series has been on wellness, and specifically how to kind of prevent moral distress. And I would say, regardless of the health system, I think all health systems have some degree of resource limitations and staff shortages. And so it's not a unique phenomenon per se to any particular place. I think that it's just probably an issue of scale. But for someone who has been working in a system where you weren't raised or trained for the last 12 years and have faced a lot of challenges and resource limitations, how do you stay so positive and engaged and interested in the work?
Yeah, a great question. And it comes in waves. There are days when it's the most rewarding work I've ever experienced. There are days when I'm ready to throw in the towel and book a ticket home. I think cultivating, your resilience is extremely important, and finding ways that when you're approaching burnout, when you're just crushed from the immense amount of challenge or just human suffering that you're privy to and experiencing firsthand, having ways where you can take care of your wellness, your mental health, your physical well-being is important, and having those to fall back on. I will say with my wife, Leanna, and I, that's been a huge difference and hugely impactful to have and form a community or find some people that you can go to for help. It is definitely more challenging going alone than with a team or with a partner. So that's one thing. That's not something easy you can, buy off Amazon or something. But I think creating structures in your site, in your life, where you'll be to know before time, not waiting when you're experiencing these situations of stress and or burnout, but having a plan beforehand as part of your pre-departure preparation can be extremely useful. But just be aware it comes and goes in waves. We sort of joke it makes you stronger, it makes you a better person, clinician, humanitarian, but it also, it affects you and it harms you. It takes its impact, and it definitely roughs you up over the years. You can't avoid that, I think, depending on where you go and what you're doing.
Thank you for the honesty. I think you're probably one of the most resilient and upbeat, positive people I've ever had the pleasure of knowing. So I really appreciate your honesty.
Yeah, having known you for just an hour, I can already feel that. So agree with Teresa there. So we have a few trainees on the call, and I guess I want to spotlight them and see if they have any particular questions. I can think of some conversations Matt and us have had around the concept of how doctors think. A question that we've discussed a little bit is whether or not that idea of the cultural influences basically on cognition, right? So, for example, you having been trained in allopathic medicine in the global north, as you think about training and working with the clinical officers or the other teams that you work with in Tanzania, would you say your approach to teaching and training is similar to what you think about when you've participated in education and training with those from the north? Or what's that like for you?
I would say, at the core, the approach is very similar. This idea, the endpoint is you want the highest quality, best care for your patient or your community or your program. I think that the nuance that it often takes 6, 12 months or more to learn is, what is the normal educational structure, country to country, region to region, and how you can kind of learn to weave into that, piggyback onto that, because it could be very different, and it could explain frustrations of why the approach I'm bringing in isn't working when for the past 12 years, they've had a completely different model of education, schooling, and even in residency training, we've seen different approaches. Some are a little more the old school. Residents and interns are crying on rounds because they're just getting pimped out with questions, versus coming in as a pediatrician, even trained in the north in allopathic. We're kinder, gentler, more compassionate. We were taught this, which I really like and have found works well, the sandwich feedback idea. I've found, at least the settings I've worked in, that sandwich feedback works really well no matter where you are in the world. People like to be complimented, appreciated, and valued before you just jump in with a little suggestion for improvement or criticism. And then, of course, finishing up with, again, more reassurance, praise. We found that really effective. We were recently talking to some internal medicine colleagues who sometimes come through, and they said in the internal medicine ward that sandwich feedback idea is sort of on its way out, and there's some new models, but personally, in our experience, has been in the teaching and mentoring setting, sandwich feedback has worked great because a lot of these learners, especially medical learners, they experience a lot more of the paternalistic, almost getting yelled at, and where they feel they're inadequate more than they've been lifted up to the idea that they're a good, hardworking, excellent clinician and doctor. So that's worked really well for us with a teaching and mentorship approach.
Thank you. One other question, Sunny, and us have chatted about living and working in other locations, right? And calling something else home. I guess I'm curious for you, you've touched upon it in many respects and super appreciative of that. Was it intentional that you would be in Tanzania as long as you have been, or did it, kind of just fall into place bit by bit as time went on? Or did you as a family say, we're going to take this leap? And yeah, I'm wondering if you can describe those initial conversations a little bit more.
Sure. So for us, we definitely wanted to do something for medium term. We were thinking initially 2 or 3 years with a program, and then reassess annually, and especially at the end of 2 or 3 years. So it's been a bit more organic for Leanne and I. Did we think we'd be here? This is now year number 12. No, that was never our thought. But it was fulfilling work. We were able to continue. The program was able to continue. It was serendipitous for us. The year we arrived was the year the clinic opened. And I think that made a huge difference and impact on us because we grew together. We weren't really an outsider trying to nudge our way into a existing, well-functioning program. We were all in it together. Our core staff from 2011, many of which are still with us. So I think that really helped. Of course, we always remember, in many ways, we're a welcome guest in any country we go to. And like any guest in any house anywhere in the world, at any second, if the host decides it's time for you to leave, you've overstayed your welcome, you sort of have to be prepared for that. And I'm referring a lot to work permits and the challenges that go with those, not only in East Africa, but around the world. They've gotten more difficult, more challenging. There's been countries with a bit of a shift towards more nationalism globally. So not only we've been affected by that, our network's been affected by that, but many global health colleagues we know have had more and more challenges. And of course, the COVID-19 pandemic has made travel and permitting difficult. So that's also something to keep in the back of your mind, that even if you want to go for more than 1 year or 2 years or 5 years, there are logistical challenges that might prevent that. And you sort of got to be ready and prepared that any year or permit could be your last permit. Also, we traveled without children. That situation has changed with children, and that is a whole nother factor and dynamic, especially as pediatricians, and something we're learning and growing and coping, but also I think recalibrates everything in life, including careers and where you're going to live and raise your child.
100%. There is a quick question for you in the chat, and then I think this will end on this. So the question comes from Yashadani, who's joined us. The question, and I might paraphrase this, is coming from the global north and North American context, that we acknowledge there's structural issues in global health, but from your perspective, what is the benefit and how can we use more of, sorry, I'm getting this wrong. what is the benefit of global health in the North American context? And then how can we, in your perspective, what is the benefit of essentially doing global health? And how can we use it more in more of the information from our studies globally? So I think it's both, how does it help your North American career, as well as how do you apply it more broadly?
Sure. And I think the answer to such a question has evolved over the past decade for sure, if not 20 or 30 years. And there is a lot. It's an important question to really think about. Is it necessary? Is it the current models and the way we're doing? Is it the right way to do it? Are there better ways to do it? I jump back even to this cash transfer ideal model. Should we consider a model where we just do more funding rather than physical presence and travel, which is costly, to say the least? And these are great questions to think about. I don't have every answer to every situation, but I do think in the clinical research realm, and maybe even more so the basic science and bench research, there are still gaps. And I think that's where North America, the global North, can be of assistance of strengthening research programs, local country research programs, lab capacity, epidemiological and surveillance capacities, where they often exist. And again, it's a lot of variation, heterogeneity regionally, country by country, but that there are definitely areas that can use just some basic foundation, building up infrastructure, teaching, so that in 5, 10, 20 years, they have a fully self-functioning research program that's accepting PhD students, postdocs, putting out amazing research. Across the world, there's some really, really great examples of those partnerships over the past 20 plus years, where now the local team is functioning well. There's even one here at our site where a research program is fully functioning, locally run, and doing amazing high level, cutting edge breaking research. So I think that's an area, but it's something to think about, and it's gonna change and evolve as the global health realm matures into adolescence, adulthood, and old age.
Well, thanks, Jason. I just want to echo what Sunny put to the chat. This was really an inspiring talk, and really appreciate you taking the time, especially because it's late at night for you. So thank you so much for sharing. Really appreciate it. And people should feel free to email you if they have questions or want to connect, right?
Yes, please feel free to reach out by email. We're happy to help in any way we can. And again, thank you for this opportunity, joining this inspiring program, and these excellent residents listening on the other side of the planet.
Well, thank you, Jason. All right, take care. Say hi to Leanne for us.
Will do. Have a great day, everyone.
You too.